So hello everyone who's joining, and thank you for being here today. For those of you who don't know, I'm Caleb Lozinski, one of the program coordinators here with the National Rural Health Resource Center, which is providing today's webinar. Today's topic is Forecasting the Future, where we will talk about the evolving challenges facing rural delivery systems. This event today is being recorded and also qualifies for ACHE credit. The credit survey where you can get the ACHE and a link to the recording will be posted, and all of that will be sent in an email following today's webinar. If you want to, you can connect your video feature so we can see all of your beautiful faces on the lower camera icon on your screen. Your audio is muted by default to avoid background noise and feedback. Please do remain muted unless you have a question, which feel free to ask if you do. To unmute your line, please select the microphone icon in the lower left corner of your screen. And if you dialed in through a phone number, to unmute, you can press *6. You can also communicate through the chat box, which is located in the bottom ribbon in the middle of your screen. If you haven't already, please take a moment to type your name, title, and organization in the chat box so we know who is joining us today. Go ahead and go to the next slide. The National Rural Health Resource Center is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. The center is the TA provider for the Delta Region Community Health Systems Development Program. The Delta Region Community Health Systems Development Program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. The center is committed to diversity, equity, inclusion, and anti-racism, and building a culture where difference is valued. You may learn more about this commitment on our website at the link below. All right. Now, before I introduce today's speaker and moderator combination, I'm going to go ahead and pull up some pre-polling. We will also launch these post-polling at the end of the session, and it helps us measure knowledge gained on today's webinar. All right. So, as part of his extensive research and evaluation activities, John Gale has more than 25 years of experience working with critical access hospitals and other rural hospitals, rural health clinics, emergency medical services, and mental health and substance use providers, and 16 years of experience managing primary care and behavioral health practices. With 41 years of experience in healthcare, John approaches his work with an understanding of the history of the decisions that have led to our current delivery systems. As well as we have our wonderful moderator today, Terry Hill. Terry Hill, the Executive Director of Rural Health Innovations and Senior Advisor for Rural Health Leadership and Policy for the National Rural Health Resource Center. I will turn things now over to John. Thank you everyone for being with us today.
Thank you, Caleb, and it really is a pleasure to be here. I've worked with teams from the National Rural Health Resource Center for many years. Terry and I are friends and go back at least 25 plus years. So it's a real treat to be able to spend some time with you. I'm going to talk a little bit about forecasting the future and what I see are some of the challenges and opportunities. I'll leave time for questions and we'll do little breaks throughout. So if a question comes up, there'll be a chance to move forward. So learning objectives, I want to go sort of share with you my thinking about what's happening in the healthcare environment that's going to impact rural hospitals and rural clinics and some of the potential impact on the folks who are trying to serve rural communities. Then I'll go through some different strategies that I think are important. There's a lot going on in the environment that may not be in the control of your organizations, your hospitals and clinics, but I do think there are things that you can do to set up now and begin thinking about and preparing for the future. So some of the strategies are reimagining the rural hospital, thinking about workforce differently, because I suspect this is a major challenge for all of you. Looking at thinking about clinical transformation, realigning services, developing a patient-centered culture, focusing on primary care, and community engagement. So to me, the idea is, can we help you build and think about building a foundation that'll set you up to succeed in the future? So I'll give you my forecasts first about the environment. And Not surprising to anyone, it's a complicated system we're in. It's a bit of a mess sometimes. But given, I think the system-wide shift from volume to value is going to continue to accelerate. Employers or and insurers really are trying to lower reimbursement and increase risk sharing with hospitals and medical groups. This is not going to go away, and this is an increasing challenge. I think in the next 5 to 10 years, healthcare costs and the affordability of care and equitable access are going to be major issues that you'll need to struggle with. And this is probably no shock to anyone, the regulatory environment is going to become more complicated and more challenging. We just cannot, the political environment we're in, the inability and our failure to think about healthcare as a system rather than individual components is making this more complicated. And by and large, if I think about major change in the US healthcare system, I don't see it happening. It's unlikely. I think we have to begin to carve away at incremental changes that move us in the right direction. And I think it's important, for me anyway, the environment for large companies, national health insurers, private equity sponsors, which makes me nervous, and national retailers is more positive than it might be for individual hospitals. They have a lot of money to put into their programs and development and advocacy. So I think these are things to think about. Yeah, this is moving a little slowly. Is it easier for you to advance my slides?
Yeah, that's also fine. Just
There we go.
say next or whatever helps.
Thank you. So here's what I see are the major challenges: increases in the pace of mergers and acquisitions. There are some of you who are independent and may want to resist that, but this is happening. We're losing essential services. How many of you are struggling with the issue of obstetrical care and delivery services in your communities? Chemo is tough. Specialty care is difficult. There's a declining need for inpatient care, and we'll get to that in a bit. And there's increased competition from non-medical providers, freestanding surgery centers, urgent care centers, and finally, the growth of value-based payment, Medicare Advantage, and managed care. Coming down the road, and these aren't hitting us quite yet, but they will. We're going to see an increased focus on containing healthcare costs. We pay more in this country for healthcare than any other industrial country across the globe. And that's going to come back and bite us. There's a demand for equity, health equity, and understanding what that means. We're seeing retail and technology health competitors, Walmart, CVS, are all investing in healthcare, and they're doing this in a way that may impact your communities. And I think we're continuing to transition away from inpatient beds in hospitals to community and homes, and I think you need to be prepared for that. Next slide. No surprises, COVID-19 has really exposed the cracks in our rural health systems. We're seeing increased risk of hospital closures, but I also think clinics and EMS is a problem. We're not talking about that enough. We're losing services. We have a low investment in public health. Our workforce is inadequate and is poorly distributed. Payment policies don't meet the needs of rural providers. And we're seeing, and most communities have fewer resources to respond to emergencies, and we'll talk a little bit about that as we go along. Collaboration is still a problem between providers, and our market-driven system favors urban delivery of services, and this is where I think rural has to organize themselves. And finally, the policy environment doesn't do much to support a systems approach to care. Each part of the industry of healthcare, from the insurers to the providers, payers, hospitals, all advocate for things that are in their best interest, but when you put it together, the system doesn't work in our best interest. Next slide. So no surprises here. A market-based system inhibits coordination. there's wasteful competition. How many of you have had clinics open up in your communities from other providers, from other systems? FQHCs and hospitals end up competing in communities. Services are distributed inefficiently. Planning gets moved from local to corporate levels. And the fee-for-service payment policies, which I won't spend too much time on, but it just doesn't meet the need of rural providers. It doesn't recognize the fixed costs. And it also discourages what I think are the most important services, which are comprehensive primary care. They're high value, but relatively low margin. Harder to make a lot of money on primary care and behavioral health than specialty care, but it's essential to keeping us healthy. Next slide, please, Caleb. So this is just a quick cartoon that I saw that I liked, and this sort of pulls it all together. We are the most expensive system in the world. We pay twice what other countries do for healthcare, or our expenditures are twice what other countries have. But it's not because we get more healthcare, we just pay a lot more for individual pieces that we get. And our outcomes are much lower. So this is the environment in which we're trying to improve rural healthcare.
And John, I'm going to jump in here for a
Please,
moment.
Terry.
I totally agree with everything you say. And basically this is product. I love this cartoon, by the way. This is the product of a pay for procedure sort of an environment. And every one of the things we've talked about, all of these problems are not going to get any better in that sort of a reimbursement system. It's all in the favor of the big urban centers. And in essence, that is why, as much as anything else, that we need to find our way in more of a value-based healthcare system. Because in a value-based healthcare system, I think we all feel as rural hospital folks that we do provide real value here. The cost is not coming, the high cost is not coming from our small rural hospitals. High cost is coming from these bigger tertiary care centers. The playing field has not been level. It's always been that those sorts of services that have been given preference, that have driven the ship. And your cartoon basically represents what happens if you don't focus on primary care, if you don't run on a relatively low margin, et cetera. And I think the real challenge here as we're looking at this is we need to find that way where we're able to document our value. And I think, I just personally feel we'll be okay. The American government or the American healthcare system, given what you just said in your cartoons, et cetera, is in for a dramatic overhaul. And so I really think that there's a brighter future. It's a scary future in that regard, but I know you're going to be talking more about that, Joe.
No, I completely agree with everything you're saying, Terry. And that's the point that I'd like you to walk away from today, is that there is important advocacy work that needs to be done that addresses payment reform, but that's not going to be easy. And quite honestly, providers are going to struggle with some of these changes. But at the same time, if you can document and show that you're creating a value-based system that's patient-centered, and if you have a Medicare Advantage program that doesn't want to include your clinic or your hospital on its provider panel because your fee-for-service costs are a little higher than they might be if you were to send someone 25, 30, or 40 miles away. But if you're showing that you're taking care of their chronic diseases and that patients are engaged and they're getting the care that they need that keeps them healthy, I think you can offset some of that, but that requires really thinking about this in a much more strategic fashion. So next slide, please, Caleb. I want to talk to you a little bit about bypass, because I think this is an important issue that we don't always understand. So the statistics that I've seen suggest that 76% of the patients who live in a rural county with a local hospital, they bypass the hospital to obtain care. It's only 35% in suburban and 23% in urban communities. And of those 76% of those patients, 68% of rural patients with a lower acuity condition that could be addressed at the local hospital still bypass them. And I think this is a real problem, because it suggests to me that there's a tension with the rural communities. If your hospital is at risk of closing, community leaders, town managers, selectmen will get up in arms about saving the hospital, but I don't think they always understand, is there a local responsibility? And so I think we need to think really about the expectations for rural hospitals and clinics. Can we that fit in the community and meet their needs? There is going to be an overemphasis on inpatient beds in the near future, and perhaps we need a different way of thinking about hospitals that lets us do the things that are needed. And I think we don't always understand the needs and use patterns of rural residents, and the only way to find out is to engage at a community level and have those conversations. I've walked into too many communities when a hospital is closed and local citizens are up in arms, and ask them, do you use the local hospital? And they said, well, no, we don't. And they don't understand the economics of healthcare. So I think to the extent that you can have those conversations with community members, it goes a long way towards thinking about solutions. So next slide,
And
please.
John, what we know, we have done tons. Our center has worked with well over 100 rural hospitals over the years. And part of this problem is your local citizens don't know what services you have available. As hard as that is to believe, we have heard it over and over and over again. So besides some of the other issues, and this is just something that if you could keep 5 to 10% more of this population in using your services, it would be a huge financial advantage.
I think that's right. We can do a lot to make sure the hospital is running and the clinic is running efficiently, but if they don't have the patients coming through the door, it's going to be tinkering around the edges. We've talked quite a bit about payment policies already. I won't spend too much time on this, but we know for clinics, RHCs, FQHCs, PPS, certain PPS hospitals and critical access, there's a volume-based enhanced payment. But it's still the fee-for-service method, which is, I think, one of the biggest problems. We pay to keep people, treat the sick, but not to keep them healthy. And I think that's where we're going to need to look at, from an advocacy point of view, a different way of compensating providers. Next slide. So here's the teeter-totter balance between value-based care. Is it dollars or is it value? And I think it's both. That we want to control costs, but absolutely just dollars alone don't tell the story. Yes, it's great to save a few dollars here and there, but if patients aren't getting better or they're not perceiving the value. So this is the balancing act you've got to try to strike. Next slide. I won't spend much time on this, but we've been struggling with rural hospitals since 1965. Going back, it's regulatory, it's finance, and we've gone through over time multiple waves of hospital and clinic closures, and we've come up with a variety of ways of supporting them, one building to the next, from the Montana access facilities to the Each Peach, the essential access community hospitals in 7 states, and then critical access nationwide. So we've created this enhanced model, but I think hospitals are still struggling and clinics are still struggling, so we need to think differently about it. The next slide. So here's where I think we start getting into some of the things that are worth looking at. So states are experimenting with different models to support their providers. Georgia has a rural hospital stabilization program that does a hub and spoke model, which is essentially networking to regionalize services. Kansas developed their primary health center model, which in many ways looks a lot like what the rural emergency hospital legislation became. Oregon does community care organizations. Alaska's done healthcare transformation. So these are things, if your states are engaging. it's worth looking at. How can you sort of take advantage of them? Then across the board, we're looking a lot at global budgets or accountable care organizations. Most of you have probably heard about the Pennsylvania rural model and the Vermont all-payer. We've had 2 rounds of demonstrations that chart from CMMI, Centers for Medicare and Medicaid Innovation, which has imploded. The HEAD model is still under development, which is a primary care function, but there are a handful of states looking at it, but I'm not sure where we're going to go. We have the Frontier Community Health Integration Program in the Western states and the Rural Emergency Hospital model. So these are all things that are happening in your environment and are probably worth keeping an eye on. Next slide. Terry, do you want to give you a chance to jump in and see if I've missed anything?
No, I think you said it very nicely, John. There's a lot of doom and gloom to some degree out there, but I think there's a lot of really positive aspects here as we're looking at this change. And I would, and I know you're going to get there in terms of what reimagining the rural hospital in that regard, but change is going to be necessary, and it's going to be absolutely necessary for rural hospitals, but it's going to be necessary for all of the big urban centers as well. They're all struggling with some of these same issues. They may have more money available to deal with some of them, but I can just tell you what we're seeing at the urban level with the big healthcare systems, et cetera, is not very promising as well. Most of these big healthcare systems are losing money. We're seeing dramatic consolidation, et cetera. So it's kind of the sign of the time that we're experiencing huge changes.
Great, thanks, Terry. Next slide, please, Caleb. So here's the context. We know the landscape is changing. What a hospital looked like 25 or 30 years ago is very different now. So there are estimates, and I think these are correct, that we will have at least 1.6 times the number of inpatient beds in 2030 than we actually need. And that many of these beds will be of the wrong type. So just think about in my lifetime in healthcare, it was not unusual for a young woman to deliver her baby in the hospital and be there for 4 or 5 days. That doesn't happen anymore. You can go in for surgical procedures and hip replacements and be out within a day or so. So those longer stays, the types of stays and things that can be done in the community are going to really challenge you. And I would argue that many critical access hospitals really don't have that many acute care inpatients as it is. The numbers are fairly small, and they tend to lean more heavily towards swing bed, skilled nursing patients, and long-term care. At the same time, you're the foundations of local delivery systems. And I think that's important to remember, that there is a role for rural hospitals as the anchors. And how can we sort of help them to become those hubs of care and look at some of the models like Hub and Spoke in Ontario. Canada has been dealing with this, and Georgia. I also think that if we look at a rural community health improvement system, this is a model that has been suggested a few times that intrigues me, and I've been looking for ways of sort of promoting this idea, is that if you get partners and providers and communities together and use the accountable communities of health model, it starts to integrate services, it brings people together, it sort of allows communities to take some responsibility for what they do and control. And finally, let's think about the service mix. You've got to focus on outpatient and ambulatory care, long-term care and support services, chronic care management, and the idea of being primary care oriented. So next slide, please. So here are some of the strategies that I'll go over quickly. We can't do all of them, but really become a more patient-centered culture, develop that culture within your facilities. enhance primary care capacity using rural health clinics and other types of models, expand high-value services. I really think that behavioral health, chronic care management, wellness, and prevention are critical pieces that you can all provide and can pay for themselves. They're not necessarily loss leaders. They're not necessarily huge, high-margin services, but they can pay for themselves. Long-term care services and supports are critical. We know our populations are aging, and a lot of hospitals are really serving an older population. Think about managing costs, collaborating with other providers to avoid duplication and efficient, and try to provide specialty services, OB care, specialty care, using telehealth and technology as necessary. I'd also encourage hospitals to think a lot about their community benefit and accountability efforts. If you're a tax-exempt hospital, you're required to do community benefit planning. There is a lot of fuss in hue and cry at the moment. There's a group called the Lowen Group that has been putting out some articles that hospitals aren't justifying their tax incentives. I think redirecting your work to do a better job. If you're already doing community benefit work, none of it's bad if you're following the IRS guidelines. Not all of it is going to be as helpful. So think about if you're going to take the time to do it right. Expanding hours. Here's the thing I think it's important. If the Walmart locally opens a clinic that is open on evenings and weekends, they're going to start pulling away your patient base. Because how many of you have had patients call a clinic locally or call an RHC or an FQHC on a Friday afternoon and be told, well, we're closing at 5, go to the hospital for an emergency, to the emergency room? You've got to be able to respond. And then think about health equity, which is important to all of us. Next slide, please, Caleb. I like this slide a lot. It's one that I've used before. It was developed by Dave Kindig from Wisconsin and George Isham, but it's done through the Partners Health Program, and it really captures to me some of the challenges. All of you have heard the focus on encouraging hospitals to address the social determinants of need. And I've had more administrators and clinicians say, oh, I'm supposed to fix poverty. I'm supposed to fix housing. I'm supposed to address all of these issues. I'm trying to care for patients and keep my door open. But this sort of breaks down the things that keep us healthy. So healthcare is about 20%. Health behaviors, the things that we do, diet, nutrition, activity, alcohol use, drinking and driving under the influence. That's about 30%. Socioeconomic factors, poverty, lack of education, lack of resources are about 40% in the environment. So as you think about this discussion, think about what's central to your mission, what capabilities you have to exercise to influence what's going on, and level of control. And I would argue the first two are where most hospitals and clinics have a real central focus and capability and control. And then think about how to work with communities in a different capacity on some of these other issues. Next slide. And here's the piece to me. I sound like a broken record, I know, but enhanced primary care is what's going to keep us happy. Healthy, I mean, excuse me, and potentially if we're healthy, we're happier too. But we don't get the primary care in this country that we need. Part of that is a policy decision. Part of it is an internal production system at the medical schools. Unfortunately, primary care docs are slightly above pediatrician and psychiatrists in terms of status, but they fall below. We've got to change that mindset, because there was a great study done by the folks at Harvard in 2019. They modeled what would happen if we added 10 additional primary care physicians, and you could expand that to think about nurse practitioners and physician assistants. So if you added 10 to a community of 100,000 people, that was associated with a 51 a day increase in life expectancy compared to a 19-day increase for 10 additional specialists. The specialists will keep you happy. It will keep people healthy. Also necessary to achieve the quintuple aims of healthcare: enhance your patient experience, better outcomes, lower costs, improve clinician satisfaction, improve health equity. Next slide. So what can you do? You can build primary care services, using clinics and other opportunities. Team-based care in doing this is really important. Can you use the folks? Can you use everyone in the team at the highest level of their license, so that registered nurse isn't making phone calls, for example, to do chronic care management and follow-up? But if you primary care would be the first piece. Wellness and prevention, chronic care management are critical. Behavioral health, which is payable. There are ways to do this. It's not easy, I won't lie to you, but it would be very helpful. And we know also that patients who have untreated behavioral health problems, depression, substance use, demand more primary care services. So you can reduce the demand on your primary care clinicians by addressing these issues. So I think and partnerships with other providers through telehealth and technology can make a big benefit, a big difference. Next slide. And health equity. You've all been I'm sure you're all hearing about health equity, and I thought a lot about this because the definitions of health equity tend to be pretty vague. But for clinics and hospitals, I have some pretty sort of concrete suggestions. Take a look at what you can control. So look at your workforce strategies and hiring strategies and policies. Does your staff, do your clinicians begin to look a little more like the people you serve in your community? Do you have policies that are all inclusive and reflect and appreciate diversity and different points of view, different cultures, different religions and ethnicities? That's a critical piece. The second is working with your providers and staff to develop cultural humility. Can you recognize the impact? And by cultural humility, I mean, do they know what they don't know? So if someone comes in to see a provider who is LGBTQ+ or comes from a different ethnic culture, do they know enough to ask the questions that will be able to help them provide services to those individuals in a way that is effective and culturally relevant to them? Look at your community benefit strategies, your community health needs assessments, and see what you can do to reach out to those vulnerable populations. And this is one that I think is important, is can you recruit members from populations you're not serving to be the bridge to help you understand their needs? Years ago, I visited a hospital who insisted that they didn't need to do community health needs assessments because everyone in the community knew them. And they shopped in the local hardware store, their kids played Little League. Everyone, they were on the Rotary Club or the Kiwanis Club. And then 2 hours later, we were talking about some new population. She said, well, it's funny. We've got this large Hispanic population who is who are now working at this food processing plant, and they don't understand us. They don't use our services, and we don't know why. And I bit my tongue and thought to myself, I thought everyone knew you. They don't. And so for this, how do you bridge people that can help you understand the culture and the needs of those populations? And this is, to me, is an essential strategy. Next slide, please, Caleb. So I won't go over these in detail, but here are some examples of rural health clinics that have developed mental health services from across the country. Regional Medical Center in Manchester, Iowa. Weeks Medical Center in Lancaster, New Hampshire, in the middle of the Lakes region, and Ozark Community Hospital. They've all built rural health clinic networks. Ozark in particular has 12 RHCs serving that sort of multi-state pocket. And they're providing direct behavioral health services. They've hired clinicians and social workers to really address those needs. And again, these are things that are worth thinking about because it's a payable service. It meets the needs that aren't being made, and it gives you a leg up on your competition. Next slide, please. Other hospital-based medical behavioral health services, Essentia St. Mary's in Wisconsin, Essentia Health, they developed a chronic care management program through the hospital where they had hospital staff and they worked with local providers. Norlea in California recognized that they had a lot of seniors who were coming through the system that weren't being served. So they created an outpatient program. They hired staff. They set up a van for transportation. Again, I think part of this is looking for those models, and we've got resources that we can share on that. So next slide. This is one that I like as an oral health program. Oral health I think is an equal problem in most communities. And this is a county hospital, Waldo County General Hospital in Maine. But they saw that a good part of their emergency department use was people presenting with pain, dental pain. And so they created this program using a variety of funds to create a program that is successful. And what they did is, if you know anything about dentistry, they are pretty protective about their patient population. They don't serve Medicaid very often, but they don't want anyone playing in their sandbox. But the hospital sat down and said, we'll take the patients that you don't want. And as it turns out, they've begun to volunteer local dentists and hygienists because it takes the burden off them and lets them contribute. So another example of things that can be done. Next slide. So wellness services, New Ulm Medical Center has done a lot around reducing heart attacks. And it's a unique hospital in Minnesota, but they've been able to really make a difference in improving, reducing the incidence of heart attacks over 10 years and increasing personal behaviors that reduce the risk. And Reddington Fairview Hospital in Maine has also created a program where they are essentially the public health department, and they develop community-based services that brings in small businesses. They offer wellness programs and do other grant funding. Again, a way of reaching out and beginning to develop a service that you may not be doing. Next slide. Terry, anything that you want to jump in?
All right. These are great examples of wellness programs, but there are things that you can do, very practical examples that will pay off. For example, we think that all rural hospitals should be doing wellness visits. Wellness visits don't have to be done by physicians. They're basically bringing in, particularly the Medicare recipients, but you could do Medicaid, et cetera. And in essence, you're basically assessing their mental health, their living situations, et cetera. It's a really low cost, low energy effort. And basically you get paid for this. If you're a critical access hospital, you're going to get paid. You're going to get paid under DRGs, I believe, as well. But what we find is that it generates primary care business for you. This is just, it's one of those things, it will pay off. We can pretty much assure you, we've looked at these over the years. And so doing wellness visits, it's just I think a giant step forward in terms of really engaging in wellness. And it helps to establish your credibility on the value-based programs.
Completely agree. And it's one of those things that seems to get lost in the mix. The other thing that it does is it makes patients feel like you're paying attention to them. Too often we go, and I do this with my own provider, I'll go in because I've got an earache or I've cut myself or done something. This is a chance for the providers to sit down and just have that conversation that looks at the whole person. So we're going to talk a little bit about workforce issues. Next slide, please, Caleb. I won't go over this too much, but just suffice to say that we have a chronic shortage of primary care services in rural communities. And nothing that I've seen suggests that over the next 10 to 12 years, we're going to solve that. So the question really becomes for me, if we go to the next slide, please, Caleb, how do we begin to use the resources we have better? Behavioral health is another one. A lot of communities Rural communities have some of the largest need for behavioral health and the lowest availability. So there's some things you can do: integrated primary care, working with specialists around using telehealth and technology. But I think if you can begin to either through partnerships or directly begin to offer some of those services. Now, the newest thing that I think is helpful for you to think about is that Medicare has recently expanded the number of clinicians that can receive direct Medicare reimbursement for behavioral health services. Used to be psychiatrists, psychologists, and social workers and other clinicians, PAs, nurse practitioners, and doctors and MDs, DOs, but you can now hire marriage and family therapists or master's level trained clinicians, which opens up the pool of staff for you. And I think that's worth exploring. Next slide, please. Workforce shortages. Here's the one. And nursing, how many of you have had to struggle with nursing and using traveling nurse services recently? I'm sure there's a number of you. So in the short term, look at team-based care, not only at the primary care level. There's the Aspirus Keweenaw Hospital in Wisconsin developed a really successful team-based nursing model where they began to use and reuse in a way that they hadn't for a while: nursing interns, technicians, LPNs, certified nursing assistants. We know that there are shortage of registered nurses. Again, we're not going to solve that in the next. If we could begin and get enough people into nursing school tomorrow to fill the need, it's still 4 to 6 years before they're ready to make a difference. So how do we develop more efficient teams and look at these examples? Community health workers are an option for many of you. And then can you use telehealth? And I think this is maybe a little further down the line, but I'm not so sure. Do you have evidence-based guidelines and artificial intelligence that can help you make some decisions and reduce the burden of decision-making so that you have standard protocols that can be implemented and require a little less and brings more consistency of the process? Next slide, please. Terry? Anything along the way?
No, I don't have a whole lot to add to that. What we're seeing, though, is a significant growth in the use of community paramedics, for example. And community paramedics were basically very valuable during the COVID pandemic, but increasingly we're finding they're showing value in terms of getting out to patients' homes. This is one of the trends that is really accelerating. Also, community health workers. That's as I think you inferred, John, that this is just another. We're developing these new type of providers that would nicely, that would supplement, your care delivery team, and it's going to be particularly important, I think, as we move into more of a value-based future.
Absolutely. And the challenge is, of course, how do we incorporate them? It isn't, I know there's been a lot of discussion of trying to find fee-for-service payment for community health workers and community paramedics, which I put into a larger, these are the paraprofessionals, which I think are critical. But I think a bigger, more important approach is how do we engage them into looking at them as an investment that pays off in reductions in costs and reduced demand on providers. It's a little less about the acute care side and more about the team base that provides value.
And John, we are doing some projects with community paramedics, helping to build community paramedics in some of our Delta region hospitals.
Mm-hmm.
And we're excited about that. In a few weeks, we're going to be working with a rural hospital in Louisiana to help them develop a community paramedic program. And then we're carefully documenting, is this program paying for itself? What kind of value is it contributing to the hospital, et cetera?
No, I think that's great, and I think it's important to expand the definition of cost. Too often we look solely at avoidable hospital inpatient admissions or emergency care, but I think it's more than that, and that's awfully hard to prove. But it's a reduction in demand on other services, some it's taking care of things that you might not otherwise. How often do we get community members? Yeah, that even such something as simple as, do they have a refrigerator that keeps their insulin at the proper level? So that getting out into their homes expands the reach of the provider, and it makes a big difference. So we'll go into a little bit into community engagement, and I want to make sure we leave some time for questions. So next slide, please, Caleb. Community engagement is critical. We've talked enough about this in the past, so I won't spend a lot of time. But I think how you reach out and work with your communities to help them understand your needs, your systems, what it takes to keep a rural hospital and a rural clinic in place can really be important. It doesn't happen enough. And it can provide some sense of ownership by community members, reduce bypass behavior, and you can help to sort of pull the pieces together. There's a model in Maine that the informed community self-determination model, which I think has some application elsewhere. But they had a community, St. George, that was struggling to pay for their EMS, emergency medical system. And they brought in providers that helped them to think about what they, what does it take? What do you need? What's the reality of their current medical EMS system, response capacity, costs, and gave them alternatives and worked through a process in the community to help them make a decision. And they actually chose, it was very successful because it brought them into the decision and helped them to understand what the investment needed to be. And to say, if you want A, B, C, this is what it costs. If you only want A and B, it's a little less. But I think that community self-determination has to be a critical piece of where we go forward. So next slide, please. Just one slide, graphic I've always used, this whole concept of patient and family centeredness and all the players in a local health system that impacts the ability of keeping patients well and their families engaged. Next slide. So Mount Scottney Hospital in Vermont is, to me, one of my favorite hospitals. The woman who ran the program, I just think so highly of. Her name was Jill Lord. It still is Jill Lord for that matter, but she has retired recently. But they've really done a lot to serve as the community hub. And she envisioned her mission as creating partnerships, giving away credit, promoting communication, and centralizing control. And they have a variety of things. Their grant writer helps local agencies to prepare grant applications. They do a lot of partnerships. They've reduced fragmentation. And it's been very successful. And I think this, again, is an example of what can be done and worth considering. Next slide. Regionalizing services. This is a tough one because this involves some level of local and state health planning, which we don't see that often, but I think it's worth exploring as we get into certain services. And for me, the perfect example is rural obstetrical care. I'll be the first to tell you, and it may be blunt, that if hospitals are only doing 25 or 30 deliveries a year, that's probably not viable. They probably can't do that well enough. But if you think about the needs in a rural community, can we regionalize these services? Can partnerships exist? So you may get 4 or 5 hospitals and clinics that are proximate to one another. Pick one hospital that's going to be the delivery system. Now there'll be a battle over that. But providing all the local services, prenatal, postnatal care, the diagnostic services, any sort of counseling goes on locally. You can do that directly or through telehealth. Do the deliveries at a designated hospital, and if it comes to issue of transportation where to transport the mother to the hospital that's doing the deliveries, we can deal with that. If it's an issue of needing supportive care for children and families during the delivery, if the partner wants to be involved at the hospital with the delivery, which we certainly always encourage, that can be done too. But this idea that having to bring back OB to every community that's losing them, I think is wishful thinking. And so we need some creativity to think about how we get that done and how we keep the services that can be delivered with quality locally done at the local community. And that would be the prenatal and postnatal work. Next slide.
John, we have an outstanding example of this kind of regionalization happening now in Arkansas. So I don't have time to go into it, but it is happening where these, and it involved both the FQHCs and rural hospitals. So I just wanted to throw that out. It's actually happening in our Mississippi Delta region.
That's great. And I think it's so important to share those models.
Yep.
So this is a tool a book that I've read recently, and I think it's worth, if anyone's interested in it. It's called 100% Community, and it's ensuring vital services for surviving and thriving. You may not be able to do all of it, but it looks at strategies and ways of thinking about food and housing and medical care that hospitals, providers, and community, and this is maybe in a perfect area for thinking about community engagement. These are the things that we need. And here's what will keep our people healthy and our community healthy. And how do we do this together? The hospital hasn't, or the clinic doesn't have to do it all. But I toss it out as a resource because it's something that I found interesting, and it sort of mirrors things that have been done, like the Camden Coalition in New Jersey. Even though it's urban, they've done a lot of this type of work, and you can do the same in rural communities. Next slide. So we know the ongoing financial risks. There's still a risk of closure. Turmoil and change are the constant themes. We know that there's reimbursement change, but again, I get back to the idea that there are things that you can do, and I think it's so important for hospitals to take control of their own destiny, to begin to build the foundation to succeed now, begin to prepare for and adapt to what's coming down the line. And if we manage to get some effective payment reform, you position well to deal with it. So next slide. Payment reform, critical. That may be out of most of our hands, but those of us who are working at the national level really have to advocate for this in a way that isn't happening now. It's got to be more than just giving providers a little bit more money. It's got to be done in a way that encourages the systems we want, thinking about models of care that deliver essential services. Technology is going to be critical. Telehealth, I mean, we are seeing more and more of it, but I think there's better ways of integrating it into our need. States and communities can think more about health planning and regionalization. I'm not a big believer necessarily in having government involved in everything. And the old days of health planning in the 70s and 80s that involved the big federal bureaucracy isn't it, but states, communities, and regions can do better. And providers, they're part of it. Community engagement, critical strategy, and we do need regulatory relief to reduce burden and encourage integration. Next slide. Closing thoughts. There are tools and resources out there to assist rural communities in taking responsibility for their care. Look at government and philanthropy to help fund these services. I think philanthropy is an interesting part in terms of grant writing to think about moving forward. States need to be involved in thinking about how they plan for services in the community. We need new delivery models, new payment models. But I think takeaway message is begin now to think about moving in the right direction by reducing costs when you can, proving your value, documenting your value, improving affordability, enhancing patient-centeredness, thinking rationally about what it is you can do and do well. We still are in a specially oriented climate where hospitals too often want specialty services. That may not be the best approach, but find that balance in doing and moving forward. So if I can get you to take anything away from this today, there are those strategies for you to think about that can really make a difference and pursue those activities. And I think that's it. My contact information, if anyone ever has questions, I'm happy to help in any way that I can. My email and my phone number is there. Please don't hesitate to reach out.
Thank you, John. And we do have about 5 minutes for questions. I have some, if other folks don't, but are there questions from listeners, from the hospitals, anything in particular? Okay, I have one, and this one is one I think John and I talked about a little bit before we started, and that is Medicare Advantage. It is now reaching close to some of our highest priorities here. And what we found, as some of you may be aware, is that we're experiencing some real problems in terms of payment for Medicare Advantage programs. Medicare Advantage, for example, just went over 50% this year. So of all the Medicare out there, we now have a slight majority is in Medicare Advantage. And the hospitals complain about getting late payments, being turned down, et cetera, et cetera. So I wonder, John, this can be a hard question. What can rural hospitals do to kind of address some of these problems, both on a short-term basis and maybe on a long-term basis?
Well, I think there are two pieces. First off, there's a lot of anecdotal evidence that talks about the problems with Medicare Advantage and denied claims, difficult authorization processes, failure to be included in panels, everything we do to control costs, at least the current environment does to control costs, is really disadvantageous to rural providers under our current rules. So the first part would be, yes, the fixed costs of some of your services may be a little bit higher, but what can you do with value that you can combat some of that? So thinking about offering chronic care management services, doing quality reporting and management so that you can share the results of your work, opening your facilities up to patients at times when they need to be there. Because if you're not available at the hours when patients need you, weekends, evenings, they're going to go elsewhere, and that's going to be more expensive, or they're going to show up in your emergency department. So think about that value equation that we've talked about all along in patient-centeredness, and then go and work with the Medicare Advantage plans and say, yeah, it may cost $15 more per visit, but we're doing these things that are going to make a difference to your patients and our patients in the long run in terms of unnecessary utilization, keeping them healthier, and working with them on it. Many Advantage plans also have wellness benefits. Can you tie into that and provide services that might be useful to patients as part of your community benefit strategy? Then the other is, if you're seeing problems with denials, referrals, or begin to collect the evidence, because unfortunately there's not clear. We know it's happening. I have no doubt that there's a problem, but the question is, if we can't prove it, then it's hard to get any traction. And I think if you're submitting claims correctly and they're being denied, or you're finding it difficult, keep records. This evidence has got to be critical. So take a look at your revenue cycle, make sure that you're doing the things that you need to do to work in that environment, to submit accurate claims, get the authorizations you need, and keep a record of those problems, but also at the same time focus on how you provide value and being able to explain that value. Rural providers are much better than I think some of these urban-based facilities assume that because you're in a rural community, you can't do things as well as an urban environment. And I don't believe that to be true. I think it's completely the opposite. But you've got to be able to sell your story. And that means quality reporting. It means having outreach to community members and being patient-centered.
Thank you so much, John. I'm going to turn it back to Caleb now. Caleb, you want to?
Yes, thank you, everyone. Thank you, John, Terry, everyone who showed up today. We are at the top of the hour here, so I'm just going to go ahead, launch the post polling. Feel free to take off after you fill those out. Again, if you want to watch the recording of this or the slides, they will be posted to the website. or if you would like ACHE credit, all of that information will go out in an email. I have scheduled to go out at 12:30 today. So again, thank you to John, thank you to Terry and everyone who is currently here. We really appreciate it and hope you join us for our next educational webinar taking place on February the 1st, if I believe. So again, thank you. Have a wonderful rest of your day and go enjoy some lunch.
Great to see everyone.
Thank you, everyone.
Bye-bye.
Bye.